CD38 predominance have a bad prognosis. Is there any reason not to use the daratumumab in those patients or to use daratumumab in those patients?
So I think, yeah, CD38 expression in CLL has been associated with a more aggressive phenotype, but I think in myeloma, the majority of patients cells express CD38. And so I can't really think of any reason why you wouldn't use this drug. It's highly effective, either alone or in combination.
You mean in CLL? You would use
No.
it?
You're asking
about CLL.
I'm just talking
No,
about
I just
myeloma.
want, this is off your
CLL I
topic.
can't comment on. I don't know what the data is for this drug in CLL.
I don't think there is any data. I just wonder if there's a theoretical reason not to use it unless it has to do with the red cells.
No, that's.
There are studies that have started, but they've not been reported yet, so I can't comment on that.
CD38 and
In
CLL.
Correct.
Thank you.
What is truly the value of driving for MRD negativity, and also by the same token, the value of this continuous concept of therapy for patients with myeloma, especially in light of what you mentioned, where you have patients with residual burden of disease that live long time? What is truly the
That's a fantastic question, and I'd look at it in a couple of ways. If I look at that cohort of patients who have the longer term survival, never in CR, none of them have high risk features. They're all low risk disease and almost all hyperdiploidy. So again, not to get too granular, but hyperdiploidy almost seems to be a different biological subtype of patients with myeloma. So I buy into the MRD negativity approach in high risk disease, because what we've learned, you take your foot off the gas, you're going to be in trouble with those high risk patients, which is, I think, in general why there has been this move to continuous therapy. Like I showed in that one slide in the first study, using lenalidomide dex 18 versus continuous, literally the 18 group at the 19th month, a significant proportion of them had started to relapse. So I would say the majority of myeloma patients do require continuous therapy. There is that small subset that perhaps don't. In the highest risk group, we absolutely want to get their disease way down, because it's, and again, we do some of this work in the lab showing that those high risk phenotypes often have multiple clones. In our clonal evolution work, we've shown that often the clone that kills the patient is the clone that was present in a small amount up front. And if it could have been eliminated, there might have been a chance for it not to become as aggressive later. Practically here today, if you have a high-risk patient, I think you want to, as much as possible, get down to CR. If you have a patient, standard risk or hyperdiploid, and you get them down to a level and they've truly plateaued, usually at a range which is close to VGPR. So these people that have, as I mentioned, long-term survival, they're not walking around with big M spikes of 2, 3, and 4. They're walking around with M spikes of 0.2, 0.3, and 0.4. There's just that residual amount, usually less than 1. You get them down to that particular level, depending on their toxicity profile, it might be very reasonable to just stop and watch, or at least to take the foot off the gas a little bit and give them less therapy so that their quality of life is maintained. I don't know if Bill, if you feel different.
Well, without being too redundant, there is this data on clonal evolution showing that the small subclones that were detectable early in the diagnosis and early in treatment later become more prevalent at subsequent relapses, and these clones tend to be the more resistant ones. And so I think the idea, and I think it's yet to be proven solidly, is that if you can eliminate those small clones early on, you can prevent perhaps subsequent resistant relapses.
Complicated answer probably, but in a nutshell, how does your approach differ in a amyloid patient who happens to have an AL underlying myeloma?
So
With
amyloid,
regards to transplant, number of regimens,
amyloid is,
IMiD.
it's really a different disease in some respects. It has some, I draw 2 overlapping circles for the residents. Say there's myeloma and there's amyloid. There's a small subset of people that really kind of meet both criteria. But I think the principles of amyloid therapy would be, the best evidence we have right now is with a proteasome inhibitor up front, likely with the Cybor D regimen, that I had the privilege of reporting first in blood. that really even now we have long-term data from that first cohort of patients, with or without transplant, have done really well. I still think in transplant eligible patients it should be considered because we've been able to show that the depth of response clearly corresponds to long-term survival in that group. The challenge with amyloid, of course, is those patients have more toxicity with almost any agent we use. So I would primarily use a bortezomib-based regimen up front. At first relapse, we like to, if at all possible, go to a pomalidomide-based regimen. Of course, clinical trial, which I think the next drug in amyloid will be the NEO-D drug, which is the antibody that can actually help melt the disease that's already prominent. The last point I'd make about amyloid, which is a little bit motherhood, but so critical, is that early rapid intervention is what saves the lives of these people. I mean, by far the most prognostic factor is significant cardiac involvement. A lot of these patients are, unfortunately, like the Titanic. You've seen the movie Titanic. The saddest point of that movie was not when Jack went down in the water, but was when the captain and the chief engineer met, and the engineer looked at him and said, "Have you breached the fifth? Has water breached the fifth room?" And he said, "Yes." He says, "We're going down. No matter what. We can't reverse the going down of the Titanic. All we can do is slow it." And so often by the time we see these patients, their light chains are so overfilled that we can't do anything about it. And I think what often happens is people get too much treatment. We've shut off the water, as it were, that's pouring in, but it's the water damage that's there that's going to kill the patient. So treating amyloid right now is all about trying to, if you will, prevent those light chains from depositing. We have nothing to reverse that deposit, which hopefully we will with the antibody. So in summary, CyBorD plus or minus transplant for at least, I treat them for the better part of a year. At relapse, pomalidomide-based regimen, and be very careful for toxicities.
Yeah, I think it's important to remember that if you look at the survival curves for most of the amyloid patients, in the first 6 months, a third of your patients are going to die, regardless of what you do. And it's because the deposition of this amyloid in the critical organs impairs function to such a degree that even if you magically can flip a switch and shut off light chain production, the damage is already there. And these are the patients, the severely damaged ones, that are just going to die regardless of what you do.
Just to elaborate on that, it was a great question because, I have a guy with amyloid and he has no evidence of any light chains whatsoever after treating him with a very short course of Velcade, but he continues to pour protein, out. And what's the natural history of that situation?
So that's an excellent point. So the most common organ involved actually is the kidney. So I know we always talk about heart disease as being, cardiac involvement as being the most prognostic, but the most common is kidney. So in that kind of situation, we often have to hold the hands of the nephrologists and say we need to give it time. So it's not perfect, but here's the analogy that I give all of my patients. They're in the exam room and there's a sink in the corner and I turn the water on the sink and I say, what if you had come into this room before I was here and the water was turned on full blast and it had filled up the sink and was pouring onto the floor? What would you do? Hopefully they say shut off the sink or shut off the faucet. Some will say like call a plumber or whatever else, right? So the bone marrow is the faucet. The peripheral blood is the sink. The floor is the kidney, right? So what we want to do is shut off the water so that there are no more light chains pouring down and damaging the floor. But what's critical, like Bill alluded to, is how much water is already on the floor. If there's a little bit of water, then maybe, I live in Arizona, right? The dry air will evaporate it and won't leave a lot of water damage to the floor. But if the water's already up to the waist, like the Titanic, it's too late. So in someone like that, you've made the first most critical step. That's why, in fact, the NEO-D, that drug, the antibody that tries to, is the MOP, get it? Or a wet vac? A wet vac is what you want for your patient. Obviously, the trial, we designed it for people who had already achieved a heme response, but didn't have the organ response yet. But in your patient, what I do is I remain patient. Because what we found is that the evaporating of the water, especially if it's after a transplant, could be up to 2 years later, which is very different than myeloma, right? Myeloma, what have you done for me lately? I want to see the M spike or the light chains go down this week or next week after I've treated you. So in that person, if their creatinine is not worsening, we have to be patient. Now, I definitely do treat them for a little bit longer because there may be even tiny amounts of light chain. So remember, amyloid is not a quantity disease, it's a quality disease. It's not how much water, it's how the water has the affinity for the floor, or how much the light chain has an affinity for the organ. Because we sometimes, I'm sure you've seen this too, Bill, we have people who barely have a light chain, but they have horrible end organ damage from it. So in your patient,
Well, there's no
I
correlation,
treat them
yeah.
for a bit longer and then
Yeah.
just wait and watch, because there's really not much else you can do.
So actually, the question I had for you wasn't that, but thank you for answering.
good.
The question I actually
Any other
had.
answers I can give before a question?
No.
Remember, Kissinger said that. He said, I have the answers, now bring me the question.
Give me the right question.
So the question I had for you actually was on carfilzomib. Do you routinely do 2D echoes in the same way that you might with a Herceptin patient every 3 months? Because I've had a couple of horrific heart failure cases that I just did not see coming. And
John, are you going to believe this is my answer? Joe, brief. No.
okay.
I don't do it.
Yeah,
I'm concerned that we will exclude people. We're doing a prospective study now.
Yeah.
We took 30 of our carfilzomib patients and we did echoes and NT-proBNPs and various other cardiac measures, even cardiac MRI in 10 of them, and have followed them through to see if we learn anything. But in general, I would not do that up front. Now, if someone develops heart failure, then obviously
that's
investigate
different.
them. I don't know, Bill, if you agree with that.
No, I don't routinely do that. Obviously, if the patient has symptoms suggestive of heart failure, if I know them
Well, it's
coming in,
obvious,
that they've got a history of it, it's a little different. But I don't screen normal patients.
And then the second question is in the patients who are at high risk for developing neuropathy or develop a neuropathy on Velcade, on VRD, do you have to, can you just switch them to a Kyprolis instead? Is that approved, or do you have to wait till they progress? I mean, what's...
Well, it depends how you define approved. If you look carefully in the ixazomib label, that switching phenomenon can occur. So we sometimes can do that. If obviously it's early on in induction and you want to use it, carfilzomib is not FDA approved as frontline therapy, but it is recognized in the NCCN guidelines as an upfront potential therapy. So if someone is developing neuropathy on subcutaneous weekly bortezomib, I'm almost always going to stop the bortezomib. Now, there may be some contexts where, let's say they're in maintenance approach or it's later on, I might drop it to every other week for a little while to see if it might improve, but you're going down a one-way path of irreversible neuropathy. So in your case, if it's still early on, there's still a burden of disease, I'd be more tempted to switch out the bortezomib for carfilzomib, yes, but ixazomib could be a consideration, and there should not be a major reimbursement issue on either of those cases.
I switch them if they start developing neuropathy. I'll also point out that about half the time, even without a history of neuropathy, you can get carfilzomib approved as initial therapy.
And then lastly, if you don't mind, so I've had some bad experiences starting off at 25 milligrams of Revlimid with the RVD regimen. Do you have a problem kind of dose escalating these people and starting off at 10? Okay.
Not at all. I think, especially in someone who's frail, older patients, you typically would start them at a lower dose, and depending on their tolerance, you can move up.
So a couple quick practical questions. The sub-Q DARA, what's the volume that they're putting in? Do you know?
I think it's over 100 mils. It's
Yes.
significant.
So where then? The second question is, where do you inject? Is
I
it?
think they were giving them in the abdomen.
Yeah. Okay.
But it's
So
actually really quite fascinating technology if you look at it, and I think Jensen was smart enough to patent it. The molecule surrounded by these micro beads that even though the volume is 100, a lot of it gets dissolved quite rapidly. So it's quite striking actually when you look at this science. If you're like a basic science geek here, this is the kind of thing to look at because it's very fascinating how that is, because you would expect, that was the first question I think I asked at ASH of Saad Usmani was, are these people going to be walking around with, balls of DARA, and they were not.
and they don't get sterile sterile pockets and things like that. That's not happening with
Correct.
that hyaluronic.
But I think we're a while away from seeing this hit
In
the
prime
market.
time, sure.
Yeah. The next question, just again on DARA, is they're doing trials now on post-progression DARA, the rituximab, you mentioned the rituximab, or are they? I mean, do we know anything about, continuing the DARA and switching the other agents with it?
You're talking about retreatment or?
Or well, like let's say you put them on Dara Lendex and they respond for a while, do great. Now they're progressing. You switch out the Len, put them on Velcade. I mean, any data or any reason why you think this might? Because you mentioned the rituximab. That's what we do in
But often
CD20s.
those patients are not progressing on therapeutic rituximab. They may be on maintenance or they're on a drug holiday. So there really isn't any evidence for that. I can tell you one study that I'm leading currently is looking at patients who progress on DARA to see if they respond to isatuximab, to see if there's a cousin or sibling-like phenomenon between those two drugs. But right now, we don't have that. Now, if I had someone who, for whatever reason, their DARA was stopped, because like looking into the future, if we're going to do DARA before transplant and then they get a transplant and they're not currently progressing on it, then I think there'd be rationale for reuse. But until we have that data, I would caution people on
Well,
using it again, continuing to use it.
Herceptin and Bev both have basically, you are radiographic progression and you're switching it out, and they are responding and do better than if you just stop it and give the other drug. So it'd be interesting to
Sure, 'cause
see
some
with
of the
time.
mechanisms we've shown that with the monoclonal antibody, there's definitely that's why it was so impressive, the data that Bill showed, that this drug has a potentiating effect to IMiDs and proteasome inhibitors.
So let's do this. We're doing great on time. I'd just like to go back to our case again. Let's go back to our original case. I just want to kind of hear what Bill and